Um, Dr. Amy, Dr. Judy, thank you so much for this opportunity. Suzanne, I think Rajul is not there, the one who nominated me. Thank you so much.
No,
Yeah,
really lovely to meet you.
yeah. I just hope I I meet with your expectations.
Of course, of course. It's just lovely to hear about the work you do.
Thank you so much.
So you might give people a few more minutes to arrive,
Sure thing.
and then I'll introduce you, and then it's all yours.
Okay.
Judy, there is another person who logged in with your credentials.
They say it was doctor. I'm leaving now. I have another meeting. I didn't know if she didn't have the link yesterday. It's our presenter.
Um,
I think it might have been me because I had to change my name, but I don't know how that happened.
yeah.
It might
Okay,
be
after
me
the
as well.
meeting, I will explain why this happens and we can try to correct it next time. Now it's kind of late, so people are entering the room.
Thank you. Sorry.
I just sent the link to doctor yesterday. She doesn't struggle to present
I
today.
think, Judy, hi, this is Minke. Good morning, everyone. I used that link as well to log in. It was the first
No,
one
you're
I
supposed to
saw.
register. Oh,
So
it's
maybe
my
it's me.
committee, but
Sorry.
okay.
Okay, people are now inside the room, so I think we can start.
Okay, great. Well, welcome everybody to the first education session for the Nutrition Network with PsyOp for 2025. Really excited to have you all here, and we have another really interesting year of educational webinars coming up. So please look out for those emails when they come through and register when you are able to attend. Tonight, my name's Amy. I'm all the way from New Zealand, so it's nighttime here for me. Yeah, really, really excited to hear this talk. So tonight we are really lucky to hear from Dr. Sripriya Mahesh. Dr. Mahesh has a PhD in nutritional sciences from Rutgers University, a master's in sports and exercise nutrition, and has over 20 years of experience. When reading into you, you have a very diverse background from a professional perspective. You've looked at things like molecular and systems biology, hospital nutrition. You've worked with drug discovery startups, working in oncology, nutrition, and medico marketing. You've worked across many fields, including designing and developing nutrition education courses, and amazingly have been a TEDx speaker. Well done. And you're head of content at the Cuddles Institute for Clinical Nutrition. So many hats, it's such an amazing background. And tonight we're really fortunate to hear you talk today about the common micronutrient deficiencies for children with cancer. You'll discuss the role of micronutrient supplementation in the context of pediatric oncology, which is a topic we are always really curious about. And then you'll share some of those actionable insights to make sure that we can create diets for our patients and our families that are nutrient rich. So welcome, Dr. Mahesh, and we're very grateful for you to be here. Thank you.
Thank you so much, Dr. Amy, for that introduction. And thank you everyone for being part of today's session. I know it's late in the evening for some people, so it's good evening and good afternoon and or good morning. At Cuddles, I had content at Cuddles, and for people who don't know what Cuddles does, Cuddles is an NGO based out of India, and we work primarily with children from the low socioeconomic group, and we provide nutritional support. And we are one of the only NGOs that primarily only works with nutrition. Having said that, uh, sorry. So let me just jump right in to the session. First, I would be addressing malnutrition, its prevalence and impact, and of course, the prevalence of malnutrition and micronutrient deficiency. I think this is something that probably is very familiar to a lot of people, but I strongly believe that It's something that is, and needs to be reiterated. And I think it also helps us understand why we are here and why we are doing what we're doing. So forgive me if some of the content is something that's extremely familiar and redundant in your view. The next part will look at the impact of micronutrient deficiency on treatment outcomes. And the last but not least, as a nutritionist, this is my favorite part, where we look at practical ways to prevent and address micronutrient deficiencies in children. So without further ado, so when we look at the 5-year net survival rates for children with cancer across the globe, what we realize is that certain parts of the globe, which is high income regions such as Europe and North America, have higher survival rates, whereas regions which are Africa, Asia, and Latin America have lower survival rates. And to explore the reasons or the barriers to higher survival have been, treat access to medical facilities, the time taken to diagnosis, and of course, nutrition. So these are factors or variables that have been explored in a lot of in the literature, and it's kind of accepted why we are seeing what we are seeing. So when we look closely, when we do a deep dive into malnutrition and we're looking at poor survival rates, we do realize that malnutrition in children who are malnourished, we see higher treatment-related side effects and toxicities, nausea, vomiting, mucositis, and severe infections. And as a result of which, this is something usually the trigger for caretakers to also, say, my child is going through too much. This is just too toxic. It's just, I'm not able to handle this. Let me abandon treatment, or let me go and seek an alternative, mode of treatment, which is less toxic for the child. Malnourishment can also lead to poor clinical outcomes, not only, and it can impact quality of life, not only during treatment for the child, but even as a survivor, it can have an impact on the quality of life they live, the burden of or long-term late effects that a child sees as a survivor. So as a result, malnourishment, this is something that we all know. It has a big or a large impact on the way a child goes through treatment and survives after that. Malnutrition in pediatric oncology, the prevalence rate, if you look at it, it's about 50 to 70% globally. Again, as everyone is aware, this variable number depends on location, type, stage of cancer, time taken to reach diagnosis, and economic status. Last year, Cuddles releases an annual report wherein we present our data, because as we are in about 43 government hospitals across India, we have a large data bank, and we look at the way undernutrition or the nutrition status changes. And what we've been seeing is that about 61% in the whole cohort is undernourished, and and overall we can say in the last 3 years, this percentage the prevalence has been kind of standard or stapled. When we speak about malnutrition, typically we talk about undernutrition, or it is thought of this, we alluded to undernutrition. But it's important to point out here that malnutrition also means overnutrition. So it encompasses both undernutrition and overnutrition. And this is something that's very familiar or very accepted in healthy children, normal healthy children. But increasingly, we are also seeing that, especially in the lower LMICs, of overnourishment in children with cancer. And you could attribute this to the nutritional transitions that we are seeing in the dietary patterns, the acceptance of more westernized kind of diets or a dietary pattern. And of course, in children with cancer, it's also about the drug protocols, the treatment protocols. For example, steroid usage in ALL that increases body fat composition and obesity. So we have to be able to address both the aspects of undernutrition and overnutrition in children with cancer. So this is an ABCD framework, and I think most of the nutritionists here would be very well aware of what this is and why we use it, right? So whenever a child comes to us in the hospital, the first thing that we do is put the child through this, the ABCD format, evaluate the child's nutritional status according to this, and then that's when a diet is planned or a diet is prescribed. So when we're looking at the first A aspect of it, which is the anthropometry, it's typically the height, weight, BMI, MUAC, and the skin fold thickness. The biochemical changes, which are changes that are reflecting in the serum, would have help us understand what are the changes in the iron level, what are the changes in glucose levels or the lipid levels, and of course micronutrient levels as well. But I would like to ask one question here. In how many of our centers, and I know we are spread across the world right now, and everyone probably has a different setup in their centers, and also the standard or the levels of cancer care is different. But one question that I think we could all ask ourselves is how frequently is micronutrient levels monitored in the hospitals throughout the cancer treatment. Coming back to the ABCD format, we have the clinical changes which are reflected in the skin and hair, and edema, which reflects protein deficiencies. The nutritionist or the clinician also reviews for mouth sores or glossitis as part of the ABCD format. The last but not least is the D, which is the dietary pattern. And this changes, the dietary pattern changes are something that's very profound and very important to be evaluated in a child with cancer. And this typically is done with either a 24-hour dietary recall or an FFQ or a food frequency questionnaire. So this helps us understand what the child has been eating like the past week, or what the child has been eating the past month or the past year. And it kind of gives us an understanding of where the child is in terms of his requirement. One thing that I personally feel is, apart from the 24-hour dietary recall and the FFQ, one other thing that needs to be evaluated is what is a usual dietary pattern. And when we say usual dietary pattern, it is the dietary pattern the child had when the child was well and healthy. This gives us an understanding of how long it has taken for the change to happen. As you know, as you're all aware, in solid cancers especially, sometimes the time to diagnosis can be long. So, but during which time frame the child has probably had a loss of appetite, he was not consuming properly. So you would actually get an idea about how far the child is from his usual intake when you're comparing the current intake. And this also gives you an understanding of how, how much, or how long has this, deficient food intake been. Another thing which, especially for the LMICs, I feel is screening them for food insecurity. Because it's one thing about giving them a prescription of a diet, saying this is what you need to consume. It's a second thing about, will they be able to afford, or will they be able to, include the items that you've given them in the diet. So which is why a usual diet pattern and food insecurity screening kind of rates a little higher for me in the dietary pattern analysis. So while we are looking at the last couple of slides, we spoke about the ABCD format, we spoke about malnutrition, we spoke about undernutrition and overnutrition, and all these are primarily geared, if you look at it, towards weight changes. We're trying to see if the child is wasted, child is stunted, is the child in the right body weight, or is he too much of body weight, or is he losing protein? So the emphasis sometimes is so much on the calories and protein that I feel sometimes, are we missing out on evaluating the macros? Are we losing sort of focus on, including that we need to also include the macros? So what are the macros? So the macros are your carbs and proteins and fats, and your micros are your vitamins and minerals. And when we talk about the definition says these are essential nutrients which are required by the body in small amounts and for normal physiological functions. And the functions of the micronutrients are something which you will find in any basic biology book, and I think this is something that we've been learning from our school years. But when you put it in the context of pediatric oncology, you realize that some of these functions are extremely important. And they kind of really match with what's required during the treatment of cancer. So micronutrients are involved in healthy immune system. They are antioxidants, powerful antioxidants, I may say. And this aspect of micronutrients are also, controversial when it comes to supplementation. So this is something that we will kind of, keep in mind. And it is involved in cellular DNA synthesis and repair. And micronutrients are also important in bone health. And this is specifically important when children are, because as children are during their growing phase, deficiency of micronutrients can impact the growth, height, especially when they have, and when a younger child has completed treatment and is now probably in his teens and is looking to grow. Energy metabolism, fatigue is something that is constant in children with cancer. So, this is another important factor, important physiological function that micronutrient governs. These days, there is a lot of talk on lycopene, resveratrol, lutein, compounds like these, which are called as phytonutrients or phytochemicals. I would like to reiterate here that phytonutrients are not micronutrients, though they are probably, I wouldn't say required, but they are probably recommended or to be taken in micronutrient amount, in micro amounts or small amounts. These are all biological plant products which have certain biological functions, but since they are not micronutrients, I have not gone through them, and it's beyond the purview of this presentation. So my doubt, I would say, or the my viewpoint on if are we really missing on micros, probably comes from this slide. This slide presents a figure from a paper wherein it compares the average intake by diet, in a cancer child compared to a healthy child. And the axis, as you can see, the y-axis basically talks about the different kinds of food groups. You have fruits, vegetables, grains, protein, dairy, fat, and water. And what you can actually see is that children with cancer are definitely consuming enough requirements of the carbs and the protein, which is your grains, which comes from grains and protein sources. However, the micronutrient sources such as fruits and vegetables, if you see, are quite lacking. And it is not matching with the recommended dietary intakes. And as a result, the contributing, the micronutrients are perhaps going to be impacted here. So this is something to think about. My session, there are periodic slides like these because I don't want to wait till the end. So this is something to think about it till now. So how often do we evaluate the adequacy of micronutrient intake in a child's diet? This is something that we need to think. And do you think it's like, do you routinely ask for it every day? Do you look at what the child is consuming? Because I know as nutritionists, we do go and ask the child what was yesterday's intake. And so do you go and map it up with the micronutrient profile and say, okay, you know what, the child is really not meeting up with the requirements? Or do you do it on a weekly basis, or do you do it on a monthly basis? This is something that, which is the best way to evaluate this? So this is something that we need to think about. Another important thing is, are we also closely monitoring the altered micronutrient requirements, which are caused by the disease or due to treatment? The average requirement that we typically, like healthy children, that we compare healthy children, is for the normal healthy child. However, in cases when a child is undergoing treatment for cancer, or is suffering, or is with cancer, we do realize that the disease can actually increase or decrease the micronutrient requirements. For example, zinc is extremely zinc is required in larger amounts, or zinc is depleted in highly proliferative cancers like lymphomas or leukemias. We also see that when the drug protocol includes cyclophosphamide, there is an increase in vitamin D breakdown. So do we think about this, and do we increase the amount of vitamin D in the child's diet? Cisplatin is another drug that comes to my mind, and we see there is an increased renal excretion of magnesium. So now, do we actually say, okay, you know what, the child is having these as the drugs? Do we really compensate it for in the diet? So these are some things that I would love for people to think about. So moving on to the next part, where we talk about micronutrient deficiency prevalence. So how do you evaluate this? Right? So there are simple 2 ways where you do serum studies, wherein you draw blood at diagnosis at periodic time intervals, and you monitor for the levels. The second, but of course, this is something that's not really practical. It's expensive, and you're poking the child multiple times. So the next easier way or easier thing is to do by dietary intake, and this is something I think all of us do a lot, wherein we look at what the child has been having, map it to the standards. I mean, every country has So using the diet or the FFQ, the food frequency questionnaire method, this was a paper by Elena in was published in 2018. In this paper, the authors, what they did was they measured micronutrient intake within standard risk and high risk ALL children. And they used 2 different types of food frequency questionnaires. One was the Harvard Service Food Frequency Questionnaire, and this was administered to children less than 5 years of age. So in this case, the caregivers filled it up. And the second one was a Youth and Adolescent Food Frequency Questionnaire, which was administered to the 5 to 18-year-olds, and they themselves filled it. And what the authors did was they kind of collected the data of the previous month. So for people who are not familiar with the FFQ, this is a sample of it. What you actually do is you go through each item. Sometimes it can be as like vast as 150 items, and then you go and check whether it's been consumed by the child once a day, twice a day, once a week, twice a week, and you keep going through this for all of this. This is time consuming, but it gives you a lot of data. So what they did find after this was there were 2 micronutrients which was really children were not meeting the dietary recommended intakes for these 2 nutrients. The first one was vitamin C, and the other one was for calcium. Zinc also was one of the minerals that children were not meeting, but this was a very like a very interesting observation, because what they did see is that zinc was the only nutrient that about 60% of the children were actually exceeding the DRIs. But this kind of gives you an idea that there are nutrients that our children are deficient in some of the important nutrients. In the next couple of slides, I'll be presenting data on prevalence data on from studies that understood prevalence from serum studies. So the most recent one, which was done in a center in India and published it came from the Dr. Bakshi lab, Samir Bakshi lab, was basically where they studied 535 patients, and they took baseline, nutritional status and serum nutrition, serum analysis, and they found that 43% of children were deficient in iron, vitamin B12, zinc, and were the other deficiencies that children were facing. And about 16% had folate deficiencies, and selenium and copper also were some of the deficiencies that they did see. Another one, which is from the western part of the world, was done in 2019. And here again, they saw that vitamin C was a deficiency, vitamin C, vitamin D, zinc, and vitamin A were deficiencies that were frequently observed. And 96% of that cohort had more than one micronutrient deficiency, and about 39% had multiple micronutrient deficiency. So this is obvious, right? Because sometimes nutrition deficiency cannot, does not stay in isolation. It's always a complex or a combination. This was another study that was published in 2018, and what this slide shows is that deficiencies that were identified at presentation continued through treatment. So the data that I showed in the previous slide were 1-point identification of deficiency status. Here, the authors studied it at 0, 3, and 6 months, and they realized that the deficiencies continued throughout the cancer treatment. So then let's, so it's the next thing that goes is, why are we seeing this micronutrient deficiencies, and what are the different reasons? As I mentioned earlier, it could be the increased rate of utilization or excretion of certain nutrients. The gut mucosal alteration is another, it's actually, there is a lot of talk about it, a lot of conversation happening around it on the impact of chemotherapy drugs on the drug mucosal layer. And zinc and vitamin C in particular have been shown to be malabsorbed in these conditions, in these situations. Iron overload, something that is also frequently seen in certain cancers, can also increase the catabolism of vitamin C and zinc. Children who are undergoing cancer typically do not get exposed to the sun, and as a result of which you do see vitamin D deficiency. And added to it, as I mentioned earlier, certain drugs increase metabolism or increase the breakdown of vitamin D. So again, that could also exacerbate the deficiencies of vitamin D. Other, like the chemotherapy-induced nausea, vomiting, side effects of other, mucositis, these can all impact the food intake of a child. And having known children are fussy eaters. In a healthy child itself is a fussy eater. So now imagine what happens when a child is undergoing treatment. He would not be wanting to eat the fruits and vegetables. There are also diet restrictions that are given in terms of side effects. For example, if there is diarrhea, sometimes certain foods are stopped. Neutropenic diets. Though we've had a lot of discussion on do we really need neutropenic diets, neutropenic diets are still part of many cancer therapy, like nutritional management of cancer children. Children with cancer. And neutropenic diets can actually be a highly restrictive diet, and you can see a reduction in fruits and vegetable consumption and a variety of other food groups that can contribute to the micronutrients. Economic background is another aspect wherein fruits and vegetables sometimes are really expensive, and the caregivers cannot afford to provide some of these. So as a result of which, there are multiple varying reasons for micronutrient deficiencies in children undergoing cancer treatment. And I think a detailed history and being able to look at it holistically is something that's very important and is required. So if you remember, this is a slide that I had in the beginning of my presentation, where I said that these are the effects that we see when a child is malnourished. But at that time, we were primarily looking at it from the lens of overweight and underweight. Now the question that we really need to ask is how many of these outcomes, right, can be attributed in part or probably are influenced by micronutrient deficiencies. This also brings us to this concept of hidden hunger. For people who are unfamiliar with hidden hunger, it's a concept wherein we speak about micronutrient deficiencies which are not that obvious. And there have been studies recently that have showed that even children who seem to have the normal weight and who we would not traditionally categorize them as undernourished or nutrition deficient would probably have nutritional deficiencies. So the concept of hidden hunger is something that needs to be explored further, not just in the undernourished child, but even in the normal nourished and the overnourished child. So again, something to think about. So what are the micronutrient deficiencies? We've established that micronutrient deficiencies are common in children with cancer. But the next time you walk into when you see a patient, when you see a child, when you walk into the hospital, which patients do we consider as micronutrient deficients? Is it the undernourished? Is it the well-nourished? Or is it the overnourished? Or is it all of the above? So this is something that is to think about. Hidden hunger was a concept that was typically used for the lower socioeconomic background, but there are studies that say that hidden hunger now does not have anything to do with economic background, and even in in backgrounds where the caregivers and the patient comes from a well-to-do background, they will still be having micronutrient deficiencies that needs addressing. So now, complicating the clinical picture of micronutrient deficiencies are how certain deficiency symptoms mirror chemo side effects, and which is why when a clinician is going in and seeing, it's very difficult to understand or estimate whether a child is deficient in a micronutrient, and if so, in which micronutrient. A few examples of this is when you look at vitamin C. Immunosuppression, and delayed wound healing are two aspects that are very similar in a deficient child, in a deficiency case, and when a child is undergoing chemotherapy. Similarly, with zinc, you have poor wound healing, you have diarrhea and fatigue and stomatitis as commonalities. Vitamin D is, it keeps coming up again and again. And if you look at bone pain and mood changes are similar between chemo side effects and deficiency symptoms. And with vitamin A, again, the increased risk of infections that's seen in deficiency in cases where there is a vitamin A deficiency. And of course, the similar thing that we see in chemo side effects. So this makes it a bit difficult for the clinician to be able to actually estimate if the child is actually deficient in a certain micronutrient, and should he or she be prescribing a micronutrient supplement, or this is something that is a chemo side effect and will probably reduce in time. But so what do we really know right now, right, about what are the micronutrient deficiencies and what is the impact on treatment outcomes? So one of the there was a paper that came out, and these are all a lot of observational data. There are not that many intervention studies, and which specifically looked at what happens. And in this cohort, what was seen was selenium and magnesium seemed to be at baseline. When they were lower at the baseline, they had higher odds of adverse clinical outcomes at baseline and at 12 months. And selenium, in fact, was the most important predictor of adverse clinical outcome in the study. Another paper which came out in 2018 looked at folate deficiency in children undergoing maintenance chemotherapy for ALL. And they realized that folate deficiency increases treatment complications such as thrombocytopenia, neutropenia, and febrile neutropenia. Why is this paper important? As we all know that the dosage levels of methotrexate, given during ALL is usually at a lower dosage, and we also know that it is an anti-folate drug. And so in that scenario, a folate deficiency has treatment-related complications. So this is something worth thinking about. Another study which looked at correlation between vitamin C levels and beta carotene levels for infections showed that deficiency of both these nutrients led to an increase in infection rates. This is a much recent study, and this was more of a prospective longitudinal study, which was done in India and got published in 2022. I'm going to delve a little deeper into this. The authors had about 535 patients. Children were included in the study, and they were followed for about a mean of 66 months. Serum levels were determined at baseline, and children, the important aspect of it was children received nutrition counseling and support during this time. What they saw was there were multiple nutritional deficiencies, and the most important ones, according to the authors, was selenium and zinc. And multiple micronutrient deficiency had an impact on event-free survival and also the overall survival of children with cancer. And what they also noticed, interestingly, that depending on the type of cancer, a particular micronutrient was more important. For example, selenium appeared to be very critical for hematological cancers, whereas zinc appeared critical for solid tumors. So the next question that we will, once we've seen this, the next question is, what are the benefits? Do we see a benefit when a micronutrient is given to a child? So as I mentioned earlier, most of the studies that are there in the literature in children are observational studies, and increased vitamin C intake has been shown to lead to fewer chemotherapy delays, reduced toxicity, and shorter hospital stays. And similarly, higher vitamin E intake has been correlated with lower incidence of infections. I would like to highlight the DAL study, which was published in 2020. And here, what they compared was, they compared children with ALL, and they compared the dietary, the adequacy of certain nutrients with the overall, outcomes, like example, bacterial infections, etc. And what they did see that antioxidants such as vitamin A, E, and zinc and carotenoids were linked to a lower incidence of mucositis during treatment. But most importantly, they actually compared a cohort of children who were consuming these nutrients through the diet and consuming through supplements. And what they saw was the dietary intake of antioxidants conferred benefits without the risks of associated with supplements. In the realm, in the scenario that we don't have very clear guidelines on how much, what is the supplement dosage that needs to be given to children. This is a recent review paper that was published where they talk about the different probable benefits of supplements and the most important key nutrients according to them that needs to be supplemented in a child with cancer. And this involves vitamin D, vitamin B12, B6, folate, vitamin C, zinc, and selenium. The conundrum of micronutrient supplementation. This is something that is often questioned, and this is where we bring back the role of some of the micronutrients having a role of antioxidants. There are controversies which says that probably administering large doses of micronutrients in the form of supplements can reduce the efficacy of chemotherapy treatment because of their ability to neutralize the essential free radical molecules. As a result of which, this is a conundrum that we still have. And adding to this conundrum is recent researches that studies or that says that the tumor microenvironment is of importance, and certain types of cancers, especially in the petri dish, seem to be growing in the presence of like vitamin D or certain specific nutrients. So the each cancer type seem to be preferring specific nutrients, and I think this is something that we really need to look into a little bit more. So the recap till now is we all know micronutrient deficiencies are poor outcomes. Studies do indicate that micronutrient sufficiency can improve treatment outcomes, and zinc, selenium, vitamin D seem to be as of now, the main key nutrients that are important